Hello and welcome to the session of lipid profile. In this session, we are discussing about lipid profile. What is lipid profile? What are the different lipids in this profile? What is good cholesterol? What is bad cholesterol? And what is the management of high lipid profile? Let's see. It is used to determine the risk of atherosclerotic cardiovascular disease. Its main application is this. Lipid profile is a blood test that measures the different type of the lipid in the blood. Hyperlipidemia means high levels of the lipid like cholesterol, triglyceride in the serum. Lipid profile assists in the screening, diagnosing and managing this type of disease. Lipid profile consists of total cholesterol, HDL, LDL, triglycerides. Now let's understand the different lipid formation and its metabolism. When we eat fat rich or cholesterol rich foods, it reaches to intestine. In the intestine, cholesterol and triglycerides are formed. The absorbed fatty acid and monoacyl glycerols are utilized to synthesize triglyceride. The majority of cholesterol absorbed by the intestine is esterified to cholesterol esters. These triglycerides and cholesterol esters are packed into the chylomicrons in the endoplasmic reticulum. So this is how chylomicron is formed. The chylomicrons are involved in the transport of dietary triglycerides and cholesterol to peripheral tissues and liver. This particle contains apolipoproteins A1, A2, A4, A5, B48, C2, C3 and E. ApoB48 is a core structural protein of chylomicron. A high fat meal leads to formation of large chylomicron particles due to increased amount of triglyceride. This is the exogenous pathway of chylomicron formation. Now let's understand the endogenous pathway. In the liver, cholesterol and triglyceride reaches from the peripheral blood and ApoB is synthesized in the liver cells. In the liver, triglycerides and cholesterol esters are transferred in the endoplasmic reticulum to newly synthesized ApoB100. The availability of triglycerides is the primary determinant of rate of VLDL synthesis. If the supply of triglyceride in the liver is limited, then newly synthesized ApoB is rapidly degraded. So this all together makes the VLDL, and this is how the VLDL is formed and it reaches to blood circulation. The loss of function mutation in either ApoB or MTP result in the failure to produce VLDL and marked decrease in the plasma triglyceride and cholesterol levels as seen in familial hypo-beta lipoproteinemia and A-beta lipoproteinemia. Other apolipoproteins VLDL contains are B100, C1, C2, C3 and E. This is the endogenous pathway of VLDL formation. Let's understand VLDL to LDL formation. In the peripheral tissue, triglyceride is removed from VLDL. VLDL particles are transported to peripheral tissue where triglycerides are hydrolyzed. The removal of triglyceride from the VLDL result in the formation of VLDL remnants. It is also called the IDL. It is called intermediate density lipoproteins. This is how IDL is formed. Now IDL reaches to liver. The remaining triglyceride in the IDL particle are hydrolyzed by the hepatic lipase. So further triglyceride is removed from the IDL and LDL is formed in the liver. This leads to further decrease in the triglyceride content and exchangeable apolipoproteins are transferred from the IDL particle to other lipoprotein leading to formation of LDL. These LDL particles predominantly contain cholesterol ester and ApoB100. Thus LDL is a product of VLDL metabolism and it reaches to bloodstream. Let's understand the LDL concentration in the blood. The level of the plasma LDL are determined by the rate of LDL production and the rate of LDL clearance, both of which are regulated by the number of LDL receptors in the liver. An increase in the number of hepatic LDL receptor increase LDL clearance leading to decrease in the plasma LDL levels, and decrease in LDL receptor shows LDL clearance leading to an increase in plasma LDL levels. The level of LDL receptor in the liver are mainly regulated by the cholesterol content of hepatocyte. As the cholesterol level in the cell decreases, the expression of LDL receptors are increased. Let's understand the HDL formation. HDL is high density lipoprotein formation. ApoA1 is synthesized in intestine and liver. First step involves the synthesis of main structural protein contained in HDL is ApoA1. ApoA1 is synthesized predominantly by liver and intestine. Then, after ApoA1 is secreted, it requires cholesterol and phospholipids that are effluxed from hepatocyte and enterocytes, and they form HDL, high density lipoprotein, and it reaches to circulation. Let's understand the reverse cholesterol transport. The peripheral cell accumulates the cholesterol through uptake of circulating lipoprotein and de novo synthesis of cholesterol. So, cholesterol is accumulated in the peripheral tissue cells. Most cells do not have mechanism for catabolizing cholesterol. In order for most cells to decrease their cholesterol content, reverse cholesterol transport is required. In this process, ABCG1 is most important. ABCG1 is ATP binding cassette transporter, plays important role in efflux of cholesterol from cells to mature HDL particles. So, cholesterol reaches to HDL from peripheral tissue cell. This HDL reaches the blood circulation. Once the cholesterol is transferred from cell to HDL, HDL reaches to blood circulation and finally in the liver. Here cholesterol is transferred from HDL to liver, and cholesterol can be converted to bile acid and can be secreted in the bile. Alternatively, cholesterol can be directly secreted into the bile. This is how cholesterol is eliminated. So, HDL particle is known as good cholesterol. Let's understand all lipids in this summary. Lipids are circulating as a lipoprotein consisting of unesterified cholesterol, triglyceride, phospholipids and proteins. There are 5 major lipoproteins in the blood. First is chylomicron. These are the large triglyceride rich particles made by intestine which are involved in the transport of dietary triglyceride and cholesterol to peripheral tissues and liver. Second is VLDL. These particles are produced by liver and they are triglyceride rich. Third is intermediate density lipoprotein, also called IDL. Fourth is low density lipoprotein. LDL carries the majority of the cholesterol that is in the circulation, and abundance of small dense LDL particles are seen in the association with hypertriglyceridemia, low HDL level, obesity, type 2 diabetes, and infectious and inflammatory states. So, this is called bad cholesterol. And fifth is high density lipoprotein, also called HDL. This particle plays important role in the reverse cholesterol transport from peripheral tissue to the liver, which is one of the potential mechanism by which HDL may be anti-atherogenic. So it is called good cholesterol. Now let's see what are the indications of lipid profile tests. Lipid profile test is indicated in the children with cardiovascular risk, like children with hypertension, obesity, diabetes and family history. In adult, it is used as a screening tool for a family history of lipid disorders. It is used to determine the risk of cardiovascular disease. In cases of pancreatitis, in the management of atherosclerotic cardiovascular disease, and it is used to evaluate the lipid lowering drugs effects. Let's understand the sample collection. For lipid profile sample, fasting is required, and it is about 8 to 12 hours of fasting. The sample is collected is a serum sample, and it can be collected in the plain tube or tube containing clot activator or serum separator tube. Most common parameters affected by the recent food intakes are triglyceride and LDL. Measurement. Total cholesterol, HDL and triglyceride are directly measured, and all other are calculations. In the LDL, total cholesterol minus HDL minus VLDL is equal to LDL. VLDL is equal to triglyceride upon 5, and total cholesterol upon HDL ratio is calculated. If it is more than 5, then it is considered to be atherogenic. ApoB/ApoA1 ratio reflects the cholesterol transport. High ApoB levels with low ApoA1 levels and high ApoB/ApoA1 ratio have been found to be strongly associated with cardiovascular disease risk. This table shows different type of cholesterol and its normal and elevated levels. We are focusing mainly on the LDL cholesterol and HDL cholesterol. The normal LDL cholesterol is less than 100 mg per dl, and ideal HDL is more than 60, but it is better if it is from 40 to 59 mg per dl in men and 50 to 59 mg per dl in women. And HDL is considered to be low if it is less than 40 mg per dl in men and less than 50 mg per dl in women. Let's understand the primary prevention of hyperlipidemia. In all age group, the lifestyle therapy is a primary intervention for the metabolic syndrome. In this primary prevention, we have to assess the ASCVD risk. So what is ASCVD? It is atherosclerotic cardiovascular disease risk. This risk calculation can be done by using online calculator that is freely available. First we see age 0 to 19 years. Lifestyle modification is very important for this age group, and if the diagnosis of familial hypercholesterolemia is confirmed, then the statin therapy should be started. Let's see age 20 to 39 years. Estimate the lifetime risk and encourage lifestyle modification to reduce ASCVD risk, and consider the statin if the family history is positive and premature ASCVD is present and LDL cholesterol is more than 160 mg per dl. In these three conditions, the statin is started in age group of 20 to 39 years. Let's see the age group of 40 to 75 years and LDL cholesterol is more than 70 and less than 190 without diabetes mellitus, and then 10-year ASCVD risk is calculated. If risk is less than 5%, then lifestyle modification is implemented. If there is borderline risk is 5% to less than 7.5%, then moderate intensity statin therapy can be recommended. If risk is more than 7.5% to less than 20%, it is intermediate risk, then statin therapy should be initiated, and it is moderate intensity statin therapy. The aim is to reduce LDL cholesterol by 30% to 49%. And if person is in the high risk category, that is risk is more than 20%, then statin therapy should be started and LDL cholesterol reduction should be more than 50%. And if the risk decision is uncertain, then CAC is calculated. What is CAC? It is coronary artery calcium and it is measured by CT scan. So coronary artery calcium is 0. It suggests lower risk, and consider no statin unless diabetes, family history, premature CHD, cigarette smoking are present. If CAC is 1 to 99, then favors the statin, especially after the age of 55, and CAC is more than 100, and if it is more than 75th percentile, then initiate the statin therapy. Let's understand if LDL cholesterol is more than 190 mg per dl in any age group, then start the high intensity statin therapy immediately. And if age is 40 to 75 years with diabetes mellitus, start moderate intensity statin therapy, and if it is not controlled, then start the high intensity statin therapy. Now let's understand the secondary ASCVD prevention. Secondary means the patient has already atherosclerotic cardiovascular disease, and after this, how we manage the patient. First, we recommend the healthy lifestyle. If ASCVD is not at very high risk and age is less than 75, then high intensity statin therapy. Goal is to reduce LDL more than 50%. If high intensity statin is not tolerated, then use the moderate intensity statin. And if on maximal statin and LDL is more than 70, then adding ezetimibe may be reasonable. So we have to add the second drug if LDL is more than 70. And if age is more than 75, initiate the moderate or high intensity statin is reasonable, and continuation of high intensity statin is reasonable. Okay. In very high risk ASCVD patients, high intensity or maximal statin is recommended. If on maximal statin and LDL-C is more than 70, then add ezetimibe as a second drug. If the second drug is also not working, then add third drug, that is PCSK9I. So how we assess ASCVD events in the patients of cardiovascular disease? These are the major events. It contains recent acute coronary syndrome within past 12 months. History of myocardial infarction other than recent acute coronary syndrome listed above. History of ischemic stroke. Symptomatic peripheral arterial disease. History of claudication with ankle brachial index less than 0.85. High risk conditions are age more than or equal to 65 years. Heterozygous familial hypercholesterolemia. History of prior coronary artery bypass surgery or PCI outside of major event. Diabetes mellitus, hypertension, chronic kidney disease, current smoking, persistently elevated LDL cholesterol despite maximally tolerated statin therapy and ezetimibe, and history of congestive heart failure. These are all called high risk conditions. So what we have discussed about high intensity, moderate intensity and low intensity statins. So now we learn what are they. So in high intensity, LDL lowering is more than or equal to 50%, and they are atorvastatin 40 or 80 mg and rosuvastatin 20 or 40 mg. In moderate intensity statins, LDL cholesterol lowering is 30 to 49%, and they are atorvastatin 10 mg to 20 mg, rosuvastatin 5 to 10 mg, simvastatin 20 to 40, and others are pravastatin, lovastatin, fluvastatin, pitavastatin. Okay. Low intensity when LDL lowering is less than 30%, and simvastatin 10 mg, and others are pravastatin, lovastatin, fluvastatin. Let's learn what are the side effects. They are called the statin associated side effects, SASE. First is myalgia, where creatine kinase is normal. It occurs in 5 to 10% of the patients receiving statins. Myositis or myopathy, where the creatine kinase is more than upper normal limit. It is a rare condition. Third is rhabdomyolysis, when creatine kinase is upper 10x into upper limit and plus renal injury is also present. It is a rare condition. The statin associated autoimmune myopathy, it is also rare. Fifth is liver transaminase elevation, where the liver enzymes are elevated more than 3 times of upper limit, and it is infrequent side effects. And sixth is hepatic failure, it is rare. These are the references for this video. Hope you like it. Thank you.